Excellent. Good morning, everyone. Thank you for joining us for our last session with Annie in the emerging drugs and drug trends. I hope you all found it helpful, valuable, and insightful in the way that it is that you understand drugs and emerging drugs within your communities, and hopefully the information you're able to take and work within the CDATs, but also within your positions. Firstly, I'd like to acknowledge the rich cultural and spiritual connections of the Aboriginal people here on the lands that I sit on, which is Wonnarua country, and all of the lands that our guests are sitting on today. I'd also like to respectfully remember the footsteps of our ancestors who have walked this land before you and I, and for all of those who follow, and also recognise those that are recognised as Aboriginal and First Nation people that are here with us today. As always, I'm going to hand it over to Annie for her to weave her magic and share her information with us, and I'll put myself on mute. Over to you, Annie.
Thank you, Gail. Thanks, everyone, for joining us for the last session today. Similar to Gail, I'd also like to acknowledge the traditional owners on whose land we're meeting today. I'm speaking to you from Benzos country up in the Northern Rivers, and I'd like to pay respects to elders, families and ancestors, and particularly extend that to any Aboriginal people that are online with us today. I'd also like to acknowledge all the people with lived experience that are joining us today, whether that be with mentally ill health or with drug and alcohol, and trust that some of the information I'm sharing today isn't too triggering for people, but please reach out to us if you find that you need some more support. So what we're going to cover today, well, we're going to look at the opioid drugs, and these are all drugs of depressant drugs. These are the ones that are more often than not implicated in overdose. So we're going to spend a bit of time talking about both heroin and synthetic opioids, which are starting to be a real problem in this country. Spend some time talking about benzodiazepines, and also share some information around harm reduction. I want to spend also a bit of time talking about naloxone, which is, if you don't know about it, is a really, really valuable tool to have in your toolkit. This is available from most needle and syringe programs, but also you can contact the New South Wales Users and AIDS Association. And then I just want to spend a little bit of time talking about stages of change and some screening and brief intervention tools that are available. And these can be a really good way to engage a client in a conversation around their drugs, their drug use. I've got some slides there, which I'm not going to go through, but Gail will send you a PDF of my presentation that just gives you some, tips about how to have a conversation about alcohol and drugs with your clients. We have some Zoom polls, so please participate in those. All your answers are anonymous, so we won't know who got them right or wrong. So let's set the scene. So why are we talking about opioid drugs? Well, as of this year, since the turn of the century, we've had 35,000 different people fatally die of overdoses in Australia. Basically, by the end of this century, that's predicted to be 1 million people in Australia, which is a huge problem. For every person that dies, there's 33 years of life that's lost per overdose deaths, and this costs us over $15 billion a year. And obviously there's lots of loss for families and friends associated with this. So what I want to do is just start off with a poll, because we did talk a little bit about stigma and discrimination in the first session for those of us who joined us. And this was a study that was conducted by the Australian Injecting Illicit Drug Users League, and it was conducted in 2012, and it basically found out that fairly high proportion of people experience discrimination from healthcare providers. So if you could just have a think about that and answer the Zoom poll there, that would be fantastic. So I've got 9 people that have voted. So I'll leave it open for another 10 seconds for those of you who haven't voted. All right, fantastic. I'm going to end the poll now. Thank you for those who shared their knowledge. They'll share the results. Well done. Most people got that one right. The correct answer is 80%. So 4 out of 5 people who inject drugs have experienced some form of discrimination from healthcare providers. And this is a really big issue because when we discriminate and stigmatise people, they're not going to access health services. So there was a study that was done in about 2008 in Australia, so it's actually 12 years old, but it estimated that there were up to 200,000 people in Australia who inject drugs. And obviously many of those also experience kind of overdose. So why are we talking about people who inject drugs? Well, they're one of the most marginalised and disadvantaged of drug users. They experience a range of health and social disparities and have unique health outcomes compared to the general population. They also have an elevated risk of mortality, with drug overdose being the main primary cause of death. So you can see here, they're more likely to suffer from fatal overdoses. Also, particularly because they inject drugs, they can get bloodborne infections, like particularly hepatitis C, but also hepatitis B, also a lot of vein damage that can happen and abscesses associated with that. They're also much more likely to experience death a lot earlier. And as we said before, they're a highly stigmatized group of people. This is just looking, this was a report that was just released a couple of months ago. So this is by the Pennington Institute, which is down in Melbourne, and they basically collect information about overdose deaths. So you can see that Australia, and this is mainly around the illicit drugs, yeah, and drugs that are injected. So we experienced, had about 2,227 people overdose. About 2/3 of those were unintentional. So there's 600 more people that die of overdose deaths than die on the roads. We had in 1999, that was the peak of our overdose deaths, and then it started to decline because there was a lot less heroin coming into this country. But then we started to see methamphetamine or ice come in quite significantly. So a lot of the population also use methamphetamine. We have also seen an increase in synthetic opioid deaths, particularly with fentanyl, which is quite a bit stronger than morphine. I'm not going to tell you how much stronger because there's a Zoom poll coming up on that. And we're also seeing a lot more drug-induced deaths involving benzodiazepines. So this was also implicated, and a lot of people, if they can't access opiate drugs, will use benzodiazepines, i.e. Valium or Xanax, because they have sort of similar type of effects. We're also seeing, non-opioid medications, so pregabalin and Lyrica, which is prescribed for strong nerve pain, being implicated in deaths. I think it's really important to understand that for every 30 overdose deaths, one of those is fatal. Sadly, you can see that third last point on the slide. First Nations people are almost 4 times more likely to overdose than non-Indigenous Australians. There's also 1 in 6 of those that are First Nations people that are in drug treatment, so highly overrepresented compared to their the population in Australia. We are seeing an increase in polydrug use deaths involving 4 or more substances, and this has been significantly increasing in the last year. So just going on to fentanyl. Fentanyl is what is actually causing a lot of the deaths over in the US, and we're about 10 years behind the US. But we are starting to sort of mirror what's happening in the US. We are, and this is quite interesting, is we are seeing more overdose deaths happening in regional areas of Australia, whereas it used to be much more situated in the city. So you can just see the different comparisons here between an overdose death in 2020 compared to 20 years ago in 2019. So in 2020, it's more likely to be, so men are 2/3 more likely than women to overdose. So it's more likely in 2020 to be a middle-aged man who's got prescription drugs like oxycodone and benzodiazepines. And that, as I said before, its death is more likely to be accidental. Whereas in 1999, which is when we were at the peak of our overdose deaths, and that's when the medically supervised injecting centre was set up in the Cross, it was more likely to be a person in their 30s with morphine and heroin and benzodiazepines detected at deaths. So what are the risk factors for opiate overdose? Well, as I said in sessions before, basically, if you mix other depressant drugs like alcohol or benzodiazepines or the tricyclic antidepressants, so these are the first generation antidepressant drugs, not so much prescribed these days anymore, and antipsychotics, this is kind of really dangerous for overdose. We are also seeing a lot more people dying when they're discharged from hospital, and this is basically because their tolerance has reduced. So if they've gone into hospital and haven't been using drugs for a while, their tolerance has dropped, and so they might go back to using the same amount that they did before, and that's a really huge risk factor. Also drug-free treatment, so if they've been through detoxification or rehab and again go back to using the same amount, this is likely to be a really big risk. We also see a really high risk after people have been released from prison. So with the first 2 weeks after being in prison release is a really, really high risk for them, and often people might go out and then celebrate the fact that they're out of prison and use the same amount as they were using before, and you know, an overdose as a result of that. So a lot of prisons now are providing people with naloxone when they leave, just to try and stop this from happening. Obviously, injecting is a lot more risky than smoking, and that's just because the drug is directly injected into the vein, whereas with smoking, it's a bit more titrated. Sometimes, and again, you know, because we don't have drug checking facilities in this country, you know, and people are just buying, you know, drugs off the street. Many people don't know what the purity of the drug is, and so therefore, or if maybe they're buying from a different dealer, and again, this can be a risk factor. Obviously, using alone is a really, because there's no one there to kind of help you either administer naloxone or call an ambulance. And we are seeing also a lot more people die who are older drug users. So I think the average age of people dying is in their 40s and 50s, and these people have had probably a lot of compromising health conditions before that. They're often also cigarette smokers. They might have also been suffering from hepatitis C, so they haven't got the same kind of resilience, I guess, to be able to recover from that. And obviously using in unfamiliar places is also a risk factor. And again, sometimes people can, if they're scared of the police and stuff, will inject the drugs really quickly and won't maybe test them beforehand. So that's, you know, a huge risk factor. So what are some of the consequences of overdose? Well, brain damage is a really big one. And the brain damage occurs quickly from lack of oxygen, as the brain consumes 20% of our oxygen supply, despite it only being 2% of the body weight. There's 2 types of brain injury can happen. So there's a hypoxic brain injury, which is caused by a reduction in oxygen, and there's an analytic anoxic brain injury where there's a complete lack of oxygen. We can also see damage happen to like physical compartment syndrome, and this is a serious condition that occurs when there's an amount of pressure on the inside muscle of the compartment. Rhabdomatosis can also happen. It's kidney failure, and this is a breakdown of the damaged skeletal muscle, and the muscle breakdown and causes the release of myoglobin into the bloodstream. And myoglobin is a protein that stores oxygen in your muscles. And if you have too much of that, it can cause kind of kidney damage. There's also trauma that can happen, and that can either be that you've witnessed that or you've experienced it. And then obviously the worst case scenario is death that can happen. And as we said, for every 30 non-fatal overdoses, one of those is fatal, and that's Australian research. So I just want to talk a little bit about pharmaceutical opioids because we've seen a massive increase in the prescribing of this. So these opioid drugs came onto the market in the mid-1990s. You probably would have been living under a rock if you hadn't heard about what was kind of happening in the US and the opiate crisis over there. So this was medicine that was really, really heavily marketed by there was a family called the Sackler family who basically developed these drugs. And they did a lot of very inappropriate prescribing. So they really targeted doctors who were already overprescribing drugs, particularly opioid drugs. And basically they got them to, and they got incentives for getting more and more prescribing. So they were marketed as drugs that you couldn't get addicted to, which was obviously not true. And they've had to pay a lot of money because this basically caused the opioid crisis in the US. So we've sort of seen 10 years later that start to happen here, and you can see that there's been a 15-fold increase in the prescribing of these drugs. And so there was very much a change from these weaker drugs to the stronger, long-acting opioids. And about 2/3 of our overdose deaths are related to pharmaceutical opioids. So with that, we're seeing a lot more people going to hospital. As a result of it, we're seeing a lot more people seeking treatment. And we're also seeing an increase in overdose as a result of that. So basically, sales grew in the US in the first year from 48 million to $1.1 billion. So really, really kind of concerning. And thankfully, there's got that under control a bit more in the US. Although what happened with the real-time prescription monitoring being brought in is that they cut off a lot of the opiate supply for these drugs, and that turned people who were dependent on it. So it's estimated that about 1 in 20 that is prescribed these opioid drugs becomes dependent on them. So this is something that was launched in New South Wales in October, just recently. In New South Wales, it's called SafeScript, and it's a software system that allows prescribers to basically keep a bit of an eye out for to ensure that people are not getting overprescribed these drugs. And you can see here that oxycodone was the most commonly dispensed opioid in Australia, and this is almost 6 million prescriptions dispensed. And this was followed by kind of codeine. So codeine, as some of you might remember, you now need a script for. So you used to be able to buy it over the counter. Well, it was under the counter. You'd still have to go to the pharmacist at the back. So from February 2018, you needed a doctor's prescription to be able to get these drugs. So this is, if you want further information about it, there's some great information available on the Your Room website from New South Wales Health. So it's a national initiative, but obviously it's rolled out differently in different states of Australia. And for us in New South Wales, it's called SafeScript. And these are the drugs that they're actually monitoring. So all of the opioid drugs, the benzodiazepines, sleeping drugs, and also psychostimulants. So dexamphetamine, dexamphetamine, and methylene. Can't pronounce that one. These are also, we've done trials with these for people who are dependent on methamphetamine, and lisdexamphetamine is a long-acting amphetamine. And some of these trials have come out with mixed results. So it's not Whereas when we did some trials on methadone, they were pretty immediately showing that they were very effective as a pharmacotherapy for opioid drugs. So we also see ketamine and progranulin and other Schedule 8 medications that are also monitored. So it'll be interesting to see what happens with this in New South Wales. Okay, I'm just going to talk about opioid drugs now and heroin. So we've got another poll here about fentanyl. So on average, how much stronger is fentanyl compared to morphine? So we've got some options up there, and as I said before, this is really what's driving the opioid crisis in America. We have found a bit of it in our drug supply here, but not to the extent that we're seeing it in the US. So I'll leave another 10 seconds for those of you who haven't voted yet. All right, I'm going to end the poll. Thank you for those that have answered, shared the results. So the correct answer is actually up to 100 times stronger. So for the person who ticked 80 times stronger, it sometimes listed in the literature as up to 80 times stronger, but it's between 80 to 100 times stronger than morphine. The great thing about naloxone, which I'll talk about in the second part of the session, is that it does actually work on reversing a fentanyl overdose, and to a lesser extent, it can also help with benzodiazepines. So thank you for answering that one. So this is so fentanyl patches. So this is really a lot of these drugs were developed for very strong cancer pain. So you can get fentanyl in patches, but also in liquid form. And the good thing is that we can you can get fentanyl strips. So these are available from a lot of NFPs. And we're encouraging people who are injecting drugs to basically test their drugs to see if they're fentanyl in them. So these are all the different opioid drugs. So obviously heroin is from the opioid poppy. It's an opium and morphine. These are like, I guess, naturally occurring ones, and codeine. And then you've got all of the synthetic and semi-synthetic opioids. So you can see fentanyl's up to 100 times stronger than morphine, and carfentanil, which was actually found in ecstasy tablets about 8 years ago in Queensland, is up to 10,000 times stronger. So carfentanil is used more often than not to tranquilize mooses. And just to give you a bit of an idea of kind of how much heroin you'd need compared to, or how much is, you know, heroin compared to fentanyl. So this is all about the same amount. So a little kind of like grain of carfentanil could actually kill you. So it's we haven't found that a lot in Australia, but we have found fentanyl, and a lot of that is coming in from China as well. So as we said, you know, these drugs have been around for a very long time. They're depressant drugs, and they basically are really, really effective for pain. And we've got, you know, all of those ones that I listed before. In 2019, so even though we don't have a high prevalence of use of these drugs, they still cause a lot of deaths in Australia. So this is data from the National Drug Strategy Household Survey. So we found that less than 0.1% of the population in New South Wales had used the drug in the previous year, but you can see how much higher that is for other prescribed opioids, so almost 3%. And these are drugs that were used not as intended. So even though they're quite low in use, you can see that they're the fourth most common drug that people are seeking treatment for in New South Wales. So we did see non-pharmaceutical drugs going down between the 2016 to 2019 survey. And this, a lot of that was believed to be because we actually had codeine reclassified. So I mean, I'm quite interested actually with what might happen now with the Taliban taking over Afghanistan, because 80% of the heroin that's produced in the world comes from Afghanistan area. And when the Taliban were in power around 2000, we saw a reduction in the amount of heroin that was available in the world. So it's a bit of a watch and see, and a lot of people working in the drugs area are quite kind of concerned about that. Most of our heroin actually comes in from Southeast Asia, no, not from Afghanistan. It's particularly refined for injection. So Australia are some of the biggest injectors in the world. So whereas most other heroin coming from Afghanistan is brown heroin, and it's more suitable for smoking. So the rock and the powder are both water soluble, so they can be injected. Most people who are using the drug in Australia are injecting it, but it can also be smoked and snorted and swallowed. And some people also whose veins are collapsed might also take it, shelve it, so take it up the bum. You can see the price of it. So it's about $50 to $75 for a point, which is 1/10 of a gram. Sometimes it's also sold in a cap, which is essentially one shot. You know, the price range, and these are prices from New South Wales, range anywhere between $250 to $400 a gram. So I don't know if, for those of you who might have attended the seminar last week, we saw that the price of heroin had slightly increased. So again, COVID didn't really impact too much our supply of drugs. So oxycodone is also available on the black market. So these are drugs that are diverted and then sold. Now, my best friend works at the Supervised Injecting Centre in Sydney, and he was sort of saying that probably about 40% of the clients that are currently using the centre are injecting methamphetamine, about 30% are injecting heroin, and about 30% are using pharmaceutical opioid drugs. So it's got lots of slang names, which are all listed there on the board. Now, I guess, you know, these are one of some, and this is why, because it's a depressant drug, you know, this is where it can be really kind of dangerous for overdose, because it can basically slow down the breathing and can lead people to go into respiratory distress. So, you know, obviously, you know, and this is why people like the drug so much, is it promotes feelings of euphoria and well-being. Very effective for pain release. Many people who might inject drugs for the first time, opiate drugs, might get, because it has a very strong central nervous system impact, can get quite nauseous and vomiting. Again, you know, people can get very sleepy and drowsy, and what is often referred to in the field as being on the nod. One of the effective campaigns that's been done by the Kirkton Road Centre is they've got a sort of saying, it's about don't ignore the snore, because that could actually be someone going into an overdose. Opiate drugs compared to stimulant drugs, you'll find a narrowing of the pupils. So pinprick pupils are basically a sign that people could be going into overdose. Whereas the stimulant drugs tend to expand the pupil sort of sizes. So again, you know, you can have a lot of risk factor associated with that. Again, you might remember from the first seminar that I presented, about 1 in 4 or 5 people who use opiate drugs become dependent on it. And that's more likely to be, you know, heroin. Whereas, as I was saying before, with pharmaceutical opioids, when they're prescribed, used as prescribed, it can be about 1 in 20. So there's many type of long-term effects also associated with them. You know, withdrawal is a really, you know, big problem with it. Even though the withdrawal is not life-threatening, it feels pretty awful with someone. Opiates, and for any people might have been prescribed these drugs because of pain that they had, you may well notice that you become kind of constipated on it. And, you know, the opposite effect when people are going into withdrawal is that they'll get quite kind of I was going to say flatulence, but that's not, they might get diarrhea and all of that type of thing. Tooth decay can happen, menstrual irregularities, infertility, infection with HIV and other bloodborne viruses can happen, and that's basically because these drugs are injected. Australia was one of the first countries in the world to introduce needle and syringe programs when we had another nasty virus on our doorstep, which was HIV. So Australian government, and this was a time when we were really progressive in our drug policy. So Australia was the first country in the world to introduce harm minimisation as part of our drug policy, and the government funded needle and syringe programs, which was really, really good. And this was based on the fact that we had about 5% of our injecting population that were estimated to have HIV. And it can be really easily transmitted, obviously, through injecting, because it's a fairly bloody behaviour that can happen. So we have less than 1% of HIV in our injecting population. But when you get about 10% within your injecting population, it can double within a year, and then it doubles every year after that. So, this was a really amazing initiative that we did. So places like Scotland, in Edinburgh, who had a really big crisis with heroin in the late 80s and 90s, they had up to 40% of their population that were injecting drugs. So again, vein damage, bacterial infections, et cetera, can be a really big problem. And many needle and syringe programs are really effective in, providing creams and access to help, and also be able to facilitate people into treatment if they want that. So this is what an opiate withdrawal looks like. So it usually starts after 12 hours of taking the last dose, and you can see some of the, effects of that. Again, the term cold turkey happens because people can kind of get goosebumps as associated with it. After 24 hours, there's a really, really strong craving that can develop, and this lasts about 2 to 4 days. So essentially, the withdrawal will be over within a week. But again, that the withdrawal, from many people I've spoken to who have been dependent on heroin, the withdrawal is the easy part. It's actually staying off the drugs and off the opiate drugs that is the more difficult part of it. So, and again, as I said before, this isn't life-threatening, but none of these symptoms are particularly nice to experience at the time. So this is where Australia has been an amazing leader, and it was amazing that, and it's been quite interesting with having COVID again on our doorstep. It was the first time that we actually allowed for takeaway doses to happen, and that we were nice again to people who inject drugs. So it's almost like it takes a virus for it to possibly affect the general population, where we actually implement better strategies. So we were one of the first countries, as I said before, to introduce needle and syringe programs. So initially it was called a needle exchange program. So you'd have to bring in a used syringe, and then you get a clean one. And they abandoned that after 5 years, and basically just would give people as many needles and syringes. And obviously we encourage disposal, and you can pick up these boxes where you can do safe disposal with them. We also implemented pharmacotherapy treatment. So for those of you who might be old enough to remember 1985, when Bob Hawke was our Prime Minister at the time, and he had a daughter who was dependent on heroin. And we rapidly expanded our methadone programs then. We also did a lot of outreach and peer education programs. So people that were often people who had had lived experience with injecting drug use, or maybe even were current drug users, would go out and provide needles and syringes and information to people about, where to go. Australia also, and it was quite interesting, I just wrote a paper a couple of years ago just around the most pragmatic thing that had happened also in our 50-year history of harm minimisation So we'll come up to that in 2026. Our current drug strategy goes up to 2026, which means that we will have had 50 years of harm minimisation. And when John Howard was in power in 1997, he basically rapidly increased diversion programs, which was a really good thing. So rather than sending people into prison, this works a lot. Police are much better at doing this for cannabis than they are for people with methamphetamine or opiate drugs, which is quite concerning. We also saw the establishment at the end of, so the medically supervised injecting centre was opened in 2000, and it was the first one that was available in the Southern Hemisphere for up to 20 years. So in 2018, there was a new one opened in Victoria, but it took a very, very long time for that to happen. The Victorian government's just approved a second one that will be happening. So the first one was in Richmond, which was where they had quite an open, street scene of heroin. And now they've got one in the city that's opening next year. Australia was also very, very late in coming to the party in releasing naloxone. So we had the first, and this is a drug that reverses the effect of an opiate overdose. This has been available in emergency medicine for up to 40 years. But we had the first programs happening in Australia in about 2012, even though they'd been happening for about 18 years in other countries. But it's quite interesting. New York has opened for the first time this week a supervised injecting facility. So these are places basically where people can bring their own drugs. They're assessed to see that they won't, and asked about what drugs they've got on board. And then they're able to get their clean sort of equipment and inject in the facility. And then there's kind of a chill out room where people are monitored and then they're able to be discharged. They're fantastic facilities. The amazing thing that's happened, there's about 30 countries in the world that have these facilities. And in the 30 years that they've been running in other countries and also in Australia, they have not had one overdose death. So what's the amazing thing about it is that they have naloxone, they have oxygen, and they're also very much connected to the ambulance. So, they've never had an overdose death. So they're a life-changing facility. A lot of the staff here, so it's either nurses or health education officers, also will help people with getting, accommodation for the night, sending them to hospital if they need more pain, also treating, abscesses and that sort of thing. So I just want to talk about opiate substitution therapy, and we have a number of pharmacotherapies available in Australia. So these drugs basically, and methadone's probably the main one that people have heard of. We have estimated about 53,000 people on the methadone program in Australia. Basically the aim of pharmacotherapy, so these are kind of legal drugs, they're still Schedule 8 drugs, but essentially what these drugs do is stop people from going into withdrawal. So methadone is a long-acting synthetic opioid, and it's administered every 24 hours. Basically people would come into a clinic or to a chemist, and they would get their dose. If they're a fairly stable user, they will sometimes be given takeaway doses. We did this again more with kind of COVID. We have another many different pharmacotherapies, which I'll talk about on the next couple of slides. Buprenorphine, which lasts a bit longer, so it's basically will hold people for 2 to 3 days, and it's used a lot more in low-income countries like India, but it's also quite popular here. So essentially, these drugs have been a game changer. It stabilizes people's lives. It enables them to get back into employment. It reduces their criminal behavior. Some people will still inject drugs on top of this. They'll use a lot less. So it's, again, a lot less likely to die from overdose. You can actually, methadone is a full agonist drug. So it will basically, it works in the same way that heroin does. So we do still get overdoses from people injecting methadone or even swallowing methadone. So methadone is the main one. It's been around since the 1960s. We have buprenorphine or Subutex, as I was saying before, that holds people for 2 to 3 days. In about 2009, we saw buprenorphine, Suboxone come onto the into the field, and basically this is 3 parts buprenorphine and 1 part naloxone. And basically this was developed by pharmaceutical companies to stop the diversion of these drugs to be used illicitly. And with the 1 part of naloxone in it, basically what it means that if you inject Suboxone, you can go into rapid withdrawal. So that's basically why that was administered. One of the really big game changers happened is that we now have depot buprenorphine. So we have 2 different forms of that, Withdrawal and Subutex, and these are basically injected under the skin. And you can see there's some information again on the left-hand side of your slide there. So it turns into a depot, and it's a slow release of it. So Withdrawal is administered either weekly. So usually they'll start people off on weekly, see how they're going. If they like it, then they'll move them on to a monthly dose. Early trials of these drugs have showed that people who inject drugs really, really enjoy it found it's really good, because they're not actually having to go into the clinic or to the chemist every day for their dose. So they can just come in monthly or weekly. And so this is basically, Withdrawal can be injected into the stomach, upper thigh, and buttock, and Subutex is always injected into the stomach area. So this has been fantastic change in the field, and it's only been around for 2 years. So if you're working with clients injecting drugs, it's really important that they know about that. Some countries also, but we don't do it in Australia, prescribe heroin. So Switzerland was the first country to do it. They conducted a heroin trial in the late 90s. But I guess one of the issues with heroin is that it's got a much longer shelf life. So it basically, people might be injecting up to 2 to 3 times a day for heroin, whereas the more synthetic forms of the drug will last a lot longer. So some doctors, it's also prescribed in the UK. So it's usually when every other treatment that people who inject drugs have tried and they want to get off drugs hasn't worked. Sometimes heroin is offered as an alternative to that. But again, we're not pragmatic enough to do that here in Australia. So just some harm reduction advice, and I'm sure a lot of people have heard of this before. Obviously, really, really important not to mix other opiate central nervous system depressants with it, because it's like a double depressant effect on your central nervous system. So that includes alcohol and Valium. GHB, gamma hydroxybutyrate, is also a depressant drug, but it's often marketed as liquid ecstasy, but it can be really dangerous if it's mixed with it. And every now and then we see an increase in the availability of that, and there seems to be a bit more of that available on the street. Obviously, because you're buying, it's a black market drug, it's really important that you try and taste a bit before. Often many people, when they might score drugs, they're quite, they often want to inject them really quickly to avoid the withdrawal. But if we, it's a really good harm reduction thing is to taste a bit first, see how the effect is before you inject the kind of whole lot of it. One of the main reasons I'm in the alcohol and drugs area is mid-80s, I lost a friend to a heroin overdose, and he scored a really, really strong dose used alone. So all of these risk factors that are kind of listed on the sort of right-hand side of your slide, Chris experienced and basically overdosed and died alone as a result of it. So he had a stronger dose than he was usually used to. It's very difficult to get people to move to a different route of administration once they've been injecting, because they get a much bigger high from it. But obviously to avoid some of the vein damage and stuff, if they can try and use the drug in a different way, maybe also if their veins are collapsing, we can try to encourage them to use in a different way. Obviously, a lot more, as we said before, damage can happen through injecting. Really important to encourage people not to share any injecting equipment. So often people will use together, they might share from the same mix. Even though we don't have a lot of HIV in our population, we still have a high prevalence of hepatitis C. And there were some studies done about 5 years ago that in Australia that sort of found within 1 year of injecting, about 50% of people had become hep C positive. So, if you're sharing a tourniquet and you release the tourniquet and it just happens to wipe over the injecting site, and that person has also an open wound, that's a hep C infection. So hepatitis C is a lot more virulent. It stays alive a lot longer outside of the body than HIV does. So it's really, really important. But from 2016, we've had amazing treatment that's available, as I talked about a couple of weeks ago. So if you've got clients that might have hepatitis C, they're really amazing kind of treatment now. The great thing about Australia's hepatitis C treatment program is that you don't need to be not using injecting drugs anymore to be available to be able to access the treatment on the pharmaceutical benefit scheme. So again, be aware of the snore. Don't just leave people to sleep it off, and be aware that the older the drug user the person is, the more likely they are to overdose. So as I said, the average age of overdoses from opioid deaths is in their late 40s. And we'll talk a little bit more about naloxone. So are there any questions about opioid drugs there, Gail, that I need to answer before I go on to benzodiazepines?
There was one question, and thank you, Dennis. He actually answered it. It was around, where does Xanax fit into those categories? And Dennis has helped us with saying it fits in the benzodiazepine area.
Excellent.
So that's the only question. And also Dennis has shared with us a little earlier that there was a recent TV series called Dope Stick, based on a book by the same name, which told the story of the Sackler family's deceptive marketing practices.
Absolutely.
So
sorry, Gail.
No, you're right. No more questions just yet.
Yeah. Look, it's a dreadful sort of story of how it all went really badly. And I guess, there's a lot of kind of suspicion around the pharmaceutical company, and these guys didn't do us any favors and they were sponsoring a lot of art events and all of that type of thing. So there was a lot of blood money that was associated with these drugs. There's also a lot of really interesting podcasts around, that, and they're quite interesting. It's in Australia, the opiate drugs, so the oxycodone and stuff, are basically distributed by Mundy Pharma. I think it's Mundy Pharma, which is basically part of the sort of Sackler family too. But they also, ironically, develop naloxone. So it's like, oh, here's the drugs you can get dependent on, and here's the drugs you can use to get over your, to prevent your overdose, which is pretty kind of like problematic. So the main benzodiazepine drugs that are used by people who inject drugs are Valium and Xanax, but also Mogadon. So there's many different forms of these drugs. As I said before, often if people can't access heroin, and certainly before the pharmaceutical opioid drugs were available, a lot of people would, mix these drugs up. It was called home bake, and make their own form of drugs are injected. One of the main problems associated with these drugs is problems with injecting, because again, there's a lot of chalk in the pills. So a lot of people can basically get, a lot of vein damage associated with that. So benzodiazepines, they're mainly, prescribed to treat anxiety and insomnia. Also used for the treatment of epilepsy and with alcohol withdrawal. So so alcohol withdrawal and benzo withdrawal are both life-threatening, but often when people are dependent on alcohol and they go to detox, they'll often give them very high amounts of benzodiazepine. So a friend of mine got quite unstuck with alcohol about 5 years ago, and he was administered to detox, and they gave him about 120 milligrams of benzos just to stop the seizures from happening with the alcohol withdrawal. So it's obviously they're legal if they're prescribed, but they're illegal if they're sold or provided to someone without a prescription. We are seeing a massive increase in prescription of benzodiazepines, but it'll be interesting to see what the real-time prescription monitoring will have on the availability of these types of drugs. So there's 30 different types of them and different generic names of benzos. They're usually swallowed, but they can also be ground up, as I said before, and mixed with water and injected, but a lot more harm can happen with the veins of them. So they're implicated in about a quarter of all opioid deaths in Australia. You can see at the bottom of the screen now.
A question.
Yeah, of course.
You've just mentioned the increasing prescription of benzos.
Mm-hmm.
Is there any reasoning behind why we're seeing that increase?
Oh, good question. I mean, look, we are seeing much more focus on kind of mental health in Australia. So, not so much focus, but discussion and people being open around their mental health. So there may well be that, doctors are prescribing them more readily than they would before. Many doctors are a bit loath to prescribe sort of Valium. Xanax has been, quite a lot prescribed. I just think a lot of people expect when they go to a doctor that they'll walk out with a prescription. I think there's, whereas there may well be other ways that people can deal with their anxiety than just using a pill for that. But I think there was a slide that I just shared earlier on that basically sort of said there was about 3 million prescriptions of benzodiazepines in Australia. So whether that's just, someone else might have some ideas around that, but I think possibly because there's been more talk and discussion around kind of mental health that doctors, because they only have 5 or 10 minutes with someone, it's easier almost to prescribe them something than it is to spend time talking with them about, how to get help and support. And maybe also that it's very difficult to, particularly with COVID on our doorstep, to see a counsellor these days. So, but they, I guess for people that have had, a trauma that's been associated maybe with someone dying and stuff like that, it's, it's more likely, they found that 6 months later, people do better with just getting psychosocial support than they do with actually getting, pills prescribed to them. So, yeah, I'm not entirely sure about that, but I'm happy to do a bit more research about that and get back to you, Gail.
Thank you.
All right. So I guess the main problem with this is they are really addictive, and they're really, only should be prescribed on a short-term basis. So basically, if people are using this every day for 2 to 3 weeks, you become dependent on them, and particularly in higher doses of it. So again, you might need a medicated withdrawal if you're using high amounts of benzodiazepines. So it's really important if you're working with clients that are regular users and using high doses of this, that they don't stop using, automatically, because then again, similar to alcohol, they can end up with a seizure as a result of it and a stroke. It's also, Valium has a very, very long what we call half-life. So it can stay in the blood up to 3 days. People can be under the impact of it. And then if you take heroin on top of that, or any opiate drug, again, you've got this double depressant effect on your central nervous system. So Xanax is a short-acting drug. It's more like about 2 days before it's in your system. Again, common withdrawal symptoms of using these drugs are insomnia and anxiety and irritability. And some of the other symptoms can include headaches and nausea and tremor and sweating, etc. And again, as I said before, very serious side effects on veins because they can result in lumpy fluid that has the potential to change circulation. So Serapax, which was a benzo that was around a couple of years ago, and it was a kind of oily constituents of its pill, and basically Kirkton Road Centre, which is a primary healthcare centre in Sydney, was noting that a lot of their clients were getting really bad vein damage, and they lobbied the pharmaceutical company to change the makeup of the pill so that it wasn't an oily form of it. So again, really important not to mix it. So harm reduction messages: don't mix with the other central nervous system depressants. Try not to use them for a longer period of time. If you want to cut down, talk to your to a doctor, a medical professional before you do it. So a lot of the needle and syringe programs used to give out pill filters for people that were injecting benzos. Unfortunately, the government started to cut funding for NSP programs, and these were the first things to go. But you can still buy pill filters from pharmacies. So, important to get that message out. And again, obviously really dangerous to drive under the influence of it, particularly if you've had a lot of those on board. Now, I just wanted to, this came out like 2 days ago. So there's a lot of sort of fake pills available on the market. So if you want to keep up to date with what's kind of happening on the peer, on the, drug alerts, this is put out by DanceWise, that are auspiced by the New South Wales Users and AIDS Association. So basically they found pills that contained fentanyl. So again, really important. So this was basically one of their peers that got in contact with them and basically had used a fentanyl test strip, and basically found that this pill had tested positive for fentanyl. And because it's so much stronger, the chance of overdose is really high. Okay, going to talk quickly about naloxone and Narcan. So basically we have 2 different versions of this available in Australia, in New South Wales. So there's the Pranoxad, which is an intramuscular form of it. And this was basically the first trials that we had of it basically involved the Pranoxad. And then a really big game changer was Nixoid, which is the intranasal one. So some of you might have had some experience with this if you've worked closely with people who inject drugs, or otherwise maybe worked in needle and syringe programs. Basically in the New South Wales trial, which we just got the results of a couple of months ago, about 2/3 of clients preferred the Nixoid than the Pranoxad. All right, so just a bit of a question for you if you haven't heard of it. This will be a bit of a guessing game. So just a question about how long you think the onset of action is for Narcan. So on average, what is the onset of action of naloxone? I'll leave you with a few minutes, 10 more seconds to answer this one. You can see 60% of people have voted. Okay, I'll shut off the poll now. Thank you for those that participated in that, and I'll share the results. And congratulations for those people who picked 2 to 5 minutes. That is the correct answer. So if it was 6 to 8 minutes or anything above that, basically there's a really great chance that the person will overdose. Again, It basically means that within 2 to 5 minutes, what this drug does is it knocks off the opiates off the receptor, off the mu receptor, and basically will reverse the effect of an overdose. So that's why it's so amazing that this is available now. But again, a real shame that Australia didn't get on the program in the 2000s when this drug started to be used a lot, and distributed to people who inject drugs. So it's been used in emergency settings for decades. It's a short-acting, what we call opium antagonist with high affinity for the mu opioid receptors. And what it does, as I said before, is it basically throws the opioids off the receptor and reverses the effect of an opiate overdose. It can cause withdrawal, but we are getting better with the dosing of this one. So if you were to give too much of this, what it can do is set someone into a rapid withdrawal. And this started to happen with the earlier, when they were doing early trials in it, and then people get quite kind of agitated and pissed off, even though you might have saved their life, they get quite kind of violent because they get into, this withdrawal phase, which, again, made them really kind of agitated. So the very first trials of peer-administered naloxone began in the ACT. So it was basically, it could be prescribed by a doctor, but basically what people did is they did the early trials of this, it was a 2-hour program on it. Now, needle and syringe programs in Australia, also they can train people up in 5 minutes on how to do it. And again, it's not rocket science. And essentially, it's a bit of a miracle. So in 2014, the World Health Organization basically endorsed making it available for people likely to administer likely to witness an overdose. So again, this is also people that might be, again, because of the, there's a lot of people that are using a lot more drugs when they're older, and even if they're prescribed opiate drugs. So if you're, pharmaceutical opioids and they might not be injecting drugs, it's really important that you have naloxone on board in the case of overdose. And it's been endorsed in the National Drug Strategy. So in 2016, took us again a very long time for it to be down-scheduled from a Schedule 4 drug to a Schedule 3 drug. Basically, with the Schedule 3 drugs, it means that you have to ask the pharmacist for it. You can't just buy it off the shelf like Panadol. And you have the Pronoxad version, which is the intramuscular version, which is the picture at the top. And then we had the intranasal version, which was only available a couple of years ago. So again, and with the trials that they did in New South Wales, they found that 2/3 of clients preferred the nasal version because it's actually much easier to administer. But then, some clients who are quite comfortable around injecting preferred the Pronoxad, but it takes a little bit more technical expertise to pull together the ampules and the syringe and stuff. So you can buy it from the pharmacist, but it is $41, whereas it's available from many NSP programs for free. Again, similar onset of action as the nasal form of it. It basically, works for 30 to 90 minutes. If you're getting no response from the person and they're not coming back to life after 2 to 3 minutes, they would recommend administering another dose. And for this one, it's more likely, as we said, to go in the thigh or the upper outer quad or the butt or the shoulder. This one, which is the most popular, so it was only available a couple of years ago, really easy to administer. It contains 2 sprays. 1 spray equals 1 dose, and a lot of people's kind of instinct is to test if it's working. Don't do that because you basically lose a dose of it. Really important to check that the nose is clear before you administer it, and you, as the picture shows there, just put your thumb underneath it and press into the nose, and it again redose again after 2 to 3 minutes if they're not coming round. If you are interested, there's a great, and I'll send people again a copy of the PowerPoint. There's a really good, and it's only a minute video, unfortunately, because I'm up in the Northern Rivers, I can't play this to you because my broadband isn't, I haven't got broadband here and not enough bandwidth to play it, but there's a really good visual on how it actually works and how to administer it. So basically New South Wales is working really hard to get naloxone programs out and running to specialist alcohol and drug services and people that are at risk of witnessing an overdose. They're available free of charge without a prescription from many community pharmacies and from NSPs, and also from the New South Wales Youth and AIDS Association. Often they'll, when we first, I worked on the first trial of this in New South Wales, and basically it was, an hour's program, and just because the doctors didn't want to let it out of their hands for a long time, people needed to be credentialed to be able to use this, whereas it's, it's pretty easy and simple to use. And as I said, you don't need to be Einstein to know how to kind of use this. In New South Wales and all jurisdictions in Australia, basically people are covered under the Good Samaritans legislation to be able to administer it. So if, someone dies as a result of it, you can't be charged. And if you want to know further information about the naloxone program in New South Wales, click on the link below when you get the PowerPoint, and you can get some information of your room. So just signs and symptoms of recognizing an overdose, again, pinpoint pupils. So the smaller the pupils, basically, the more chance there is of someone's going to overdose. Pale skin, blue tips and this is basically deprivation of oxygen. If the person doesn't respond when you're shouting at them or shaking them, again, really, really important, that they administer naloxone. If they're loss of consciousness and can't be woken, this is the time to administer it. And if their breathing is slow and shallow and they're snoring, so don't ignore the snore, administer naloxone. So the first thing to do is actually to call an ambulance, monitor the breathing and consciousness, use the recovery position, stay with the client until help arrives with them. And if they're using opiate drugs, give them naloxone. So even though it's not developed for benzodiazepines, they have found that it can work in some cases also with benzodiazepines and Valium. So again, it's not designed for that, but it can actually work in some cases, and some clinical trials have found that it actually does work with those. Any questions about that before I quickly take you through stages of change or screening or brief interventions? I can't see there's any more come in. Anyone?
No more in the chat function. Anybody want to open? Sorry, anybody want to open their mic and ask a question?
No. Or shy?
Quiet lot today.
Okay, it's Friday after all. Okay, so some people who've been in the field for a while might have heard about this. This is stages of change. We've used this a lot in the alcohol and drugs field to basically find out more about how people respond to treatment. So it was basically developed in the late 80s by Prochaska and Di Clementi. And it basically sort of says that people who are trying to, who are currently using drugs or might even want to give them up are in sort of 6 definite stages of change. Many people are in what we would call the pre-contemplation stage. So they're not really aware that their drug use might be causing them problems. And so where this is really helpful for those that are working with people who use drugs is basically what we're trying to do, and this is where harm reduction becomes really, really important, is try to move people into the contemplation phase. So this is the opportunity for education, looking at some of the pros and cons of their drug use, and again, trying to move them into preparation and action and maintenance and relapse. And again, sometimes people can have what we would call a lapse rather than a full relapse. It doesn't mean that they need to go right back to the beginning again. But again, it's a really kind of effective way to kind of understand where people's alcohol and drug use might be. And they estimate that about 60% of people that are currently using are in this pre-contemplation sort of stage. They may well be in contemplation stage where they're aware that their drug use is becoming a problem, but they have no commitment to action. And so this is where harm reduction can kind of facilitate people into making changes around their drug use. So it's basically been really, really heavily researched. And it was used in a number of studies in the early days around smoking, and then it's been applied to many other kind of like health behaviours. So people don't suddenly wake up one day and go, I want to necessarily be drug free. And again, it's about exploring with the client. Maybe they just want to reduce their drug use and reduce some of the harms associated with it. Yeah, so as a bit of a rule of thumb, about 40% are in pre-contemplation, 40% are in contemplation, and about 20% of people are in the preparation phase. And again, for all of us working with people who use drugs, we can help at any of these kind of stages into facilitating them. Some of the screening tools that I'm going to just take you through today, not there yet, are basically all in the public domain. So I think, depending on, which drugs are an issue for your client, these can be really good. And I don't call them kind of clinical things like the severity of dependence scale or the alcohol use disorders test. They sound a bit kind of scary and clinical. But you can just sort of say, talk to a client about, hey, do you want to find out a bit more about your drug use or your alcohol use? And these are some of the sort of things that you can do with them. What they've found, and these have all these screening tools have basically been around forever. And basically what they do is find out if there is a problem. And find the problem basically with screening, to find the problem. Screening can find out whether or not there's a problem, and they can give you some really good indicators of where that person is with their drug use. So a lot of and even though these were developed originally for clinicians, it's not to say that those of you who are working with people who use drugs can't use them in yourself. The great thing that they've found through research with administering some of these kind of screening tools is just actually doing the tool in itself can get people to think about their drug use in a way that they hadn't. And so what they've found after 3 months and sometimes 6 months follow-up, even when people didn't get a brief intervention or have a conversation with a clinician about it, that they'd seen some reductions in their alcohol and drug use. So there's on the left-hand side of your screen, there is the audit, which is basically used for alcohol. So this was administered developed in the late 80s. These are all developed by the World Health Organization. We've also got a test for nicotine dependence. And the other one that's amazing is the assist, which basically covers screens for 10 drugs at the same time. Questions, it's in the public domain, you can train yourself on doing it, but again, even just getting the client to do it themselves can get them to reduce their alcohol and drug use. So this is the SDS, so you can basically replace the word cannabis with any other drug. You've got a maximum score of 15 for this test. This is not a test you want to pass. The lower the score, the better the results. Obviously, the higher the score, the more entrenched the dependence is, and the more difficulty it will be to treat. So this one, this is the SDS for cannabis, but you can replace, as I said, cannabis for any other drug. So the lower scores would indicate again, less of an issue. The assist, so basically this is basically Professor Robert Allais, who works in South Australia. He works for World Health Organization, but he's developed a whole lot of fantastic videos and tools to show you how this can be administered. So this is the assist portal. It was developed 10 years after the audit. It's undergone sort of testing to ensure that it's valid and reliable and cross-culturally relevant, also across genders. It can be used in primary healthcare settings. I've been training up youth workers to use this with their clients, and it's worked really well. And it the great thing about the assist is it identifies substance use that might not be dependent, but might be causing problems and harms, and it screens for all levels of risky drug use. So it's 8 questions. It collects information about, all of those drugs. It also has 2 other areas where you can sort of fill in other drugs that might be an issue, say synthetic cannabis, or and it basically has one thing for amphetamine type stimulants, and that would cover MDMA and basically maybe methamphetamine as they'd be using them. So I would just put in methamphetamine for the amphetamine type substances, and then add MDMA, and I'll show you what the screens look like and all the questions look like. So it basically will, at the end of it, put clients in a low, moderate or high risk, but it'll do that for all of the drugs that you've asked about. And basically, again, similar to the other screening tools, it will determine the level of intervention required. So treatment as usual basically means it's not really a problem. Brief intervention is an opportunity to provide some harm reduction information to them. And if they score very highly, then it basically indicates that you will need to refer them into a specialist treatment service. It takes about 5 minutes to administer. You can either do it to the client or they can do it themselves. And if the person's willing to share the score with you, then it's about having a conversation with them to discuss some of their drug use, pros and cons, all of that type of thing. So this is what the scores mean.
I think Mandy might have a question. She popped her hand up just a minute ago.
Yes. Yep.
Yeah, I was actually just going to write it in the chat. I just had it, I was just thinking, given that the CDAT program sort of has that prevention focus, and there's often a lot of CDAT members are sort of not necessarily health workers as such, or even social workers. How do you have any thoughts about how the CDAT program might be able to integrate the sort of the screening kind of tools into how we work, or the sort of activities that we?
Well, I think, so I do a lot of training with youth workers, people who work in mental health and people who work with homelessness. So obviously drug use isn't, their number one kind of priority area, but most of their clients will be using drugs, which is why they might be accessing the service. So these I think the reason I wanted to sort of share these is it just can be a really good opportunity to have a discussion with a client about their drug use. So you don't need to be a clinician to be able to do this. They were originally developed by for clinicians' use, but a lot of these are used in primary healthcare setting. So, for example, the audit, if someone were to come to accident and emergency because of an alcohol-related injury, or they go to a sobering up shelter or something like that, before they would discharge them, they would do the audit with them. So it's more if you've got an established relationship with a client, or you're working with clients that might be using drugs, these can be a way to start a conversation with someone, but then not bring it up in a kind of clinical way. So it's more, I know there's a lot of people within CDATs that are working in, other related services where drug use might not be their primary cause of concern, but a lot of their clients are basically, drug use might be one of the reasons that they're accessing the service. Does that answer your question?
Yeah, definitely. And I think a lot of CDAT members can be from like community centres and sort of neighbourhood centres, and sort of organise that grassroots kind of organisation. So it could be as CDAT members or CDATs around even just bringing up that these tools exist and how they might be used in those sort of settings. Yeah,
absolutely. Absolutely. So again, I wouldn't use the word, I would avoid clinical language in this, just use your own kind of like language for it. Hey, there's, and it may well just sort of say, hey, I went to this training the other day and they were talking about this, quiz that you can do to look at your drug use. And most people, if you've got a good rapport with them, like talking about their drug use, and so this can be, bring it up in a really kind of casual way, and basically obviously ensure the confidentiality. The great thing about the assist is that they can just do it themselves, and they will get the scores at the end and they can just read the results of that. So, but if you've got a good rapport with them and they want to share their scores with you, then it's an opportunity for a conversation, and it's like, oh, you scored quite highly on your methamphetamine use, you know, and I'll just share some information there about how to administer a brief intervention and some of the conversations we can have. So I've filled, so this is basically the different questions that are in the assist. I filled this out as if I had used a lot of drugs, and it was just more to show you kind of like how it spits out your scores at the end. So the first question asks, in your life, which of the following drugs have you ever used? And you can see the 8 different drugs that are listed there, and then there's 2 options there for other substances. So I filled in bath salts, which is basically like research chemicals. These were popular about 10 years ago. And these are bath salts were, well, they were called bath salts, but these were when there was very reduction in the purity of MDMA. These were quite available at the time. So where you can see amphetamine type stimulants. So we've got speed, meth, ecstasy. Well, a lot of people will use both speed and ecstasy. So I would again put as my other substance down there, MDMA or ecstasy, so that you can put in a different score. The second question asks, in the past 3 months, how often have you used them? And again, the great thing about this, so this is there's a paper version of this, but the paper version is much more cumbersome to use. And the advantage of the electronic version is it disables the questions that you don't need to ask about. So you can see that we're moving more into what's going on in the present for you. You can see that because I didn't fill in a 10th drug there, it's basically disabled it. And you can starting to see a bit of a pattern here is that, you know, okay, this person's using alcohol, cannabis and tobacco on a daily level. So possibly this is, you know, where we'll find some problems coming. So in the past 3 months, how often had you a strong desire to use these drugs? And you can see again, all of the drugs that weren't used in the 3 months previously have been disabled. So there's no, you know, you don't need to kind of go back to the paper version and find out. And you can see again here, the daily, almost daily is coming up as an issue. Whereas cocaine and amphetamines and Valium hadn't been used hadn't had a strong desire to use them. In the past 3 months, how often has your use of a substance led to health, social or legal or financial issues? Well, if you're a smoker in Australia, you're spending up to sometimes up to $8,000 a year on your habit, depending on how much you smoke. But as we sort of talked about in webinar number 2, Australia is one of the most expensive places to smoke. But you can see, you know, and many clients might also be experiencing some financial problems around their tobacco use. And you can see here, you know, that again, the drugs that have been disabled. During the past 3 months, how often you failed to do what was normally expected because of your substance use? Tobacco is not included in this question because basically it's not psychoactive in the way that the other drugs were. In fact, people that are dependent smokers may well find that it's problematic if they don't, they'll get quite agitated and whatever if they don't have them. But again, you know, and the great thing, as I said before, is it adds up the scores for you. So again, we're starting to see a bit of a pattern here where, you know, this person isn't necessarily having financial problems with it or, you know, doing things that they wouldn't normally do. Again, this is basically someone's noticed that your drug use might be a problem. So sort of, you know, someone close to you or maybe a healthcare provider that sort of had a conversation with you, and it's basically an indication of that your drug use might be starting to get problematic. So again, you know, tobacco, alcohol and cannabis are coming up here, and the other drugs are not so much ever. The last question 7 is if you had tried to cut down and been unsuccessful in your attempt. So this is actually showing awareness about the fact that your drug use has been an issue. You can see that, you know, cannabis and alcohol and tobacco are coming up as red flags. And then the final question is, have you ever used a drug by injection? And again, this would also indicate sort of like problems. And this is what you get at the end of it. So you can see here that we've got a risk score of 22 for tobacco, 18 for alcohol and 25 for cannabis. Now, you know, the assist has calculated that up as a moderate risk score. and indicating that a brief intervention is required. And a brief intervention essentially means having a conversation with that person about their drug use. The other drugs have got low to moderate, low levels of use, which basically mean they're not issues with that. Now, if you click on this link down here, print the completed assist feedback card, you can basically get a copy of this online, which you can give then to the client, or, and provides a little bit of information to them. This is what a brief intervention consists of. Ask your client whether they want to find out what their score is. Obviously, if they've completed themselves, they'll have that. You can give some feedback about the score using the report card. Obviously, advise the client that they can reduce their risk by reducing their drug use. Let the client know what it's up to them with what they do with the information today. A lot of people say that's really interesting, or, and many people will often be surprised by some of the results that they get out of it. And again, you can drag a horse to water, but you can't force them to drink it. And if they are not interested in finding out more information, then that's okay. You can ask them if they're concerned about their score for the drugs, what, how and why. And this is all done for those of you who've worked with motivational enhancement techniques. This is all done in a motivational way. One of the things that we often talk about, what are the good things about your drugs? What are some of the less good things about it? And it might well be, well, I've noticed I've started coughing in the morning, or I've noticed I'm spending a lot more money on drugs, or I'm noticing I'm coming late to work or to school or whatever. And if you're feeling confident about that, you can even put a score of 1 to 10 on those pros and cons. And this is something we talk about as the decisional balance. And if the pros have got a higher score than the cons, then again, indicating that they're probably in the pre-contemplation stage. So it really gives you some sort of guidance about how to guide your questions. Summarize, reflect back your discussion. You can ask them, how concerned are you about the less good things? If they say, nah, look, it's not really a problem for me. I think a really good question to ask is, when would you know that your drug use is of concern? And what this is basically doing is priming the brain for the fact, oh, I get pulled over by the police again, or I have an accident, or, my partner leaves me, or whatever. And that's basically sort of saying to them, okay, this might be an opportunity that they come back and have more of a discussion with you, or maybe facilitate themselves into treatment. So you can give them some of the harm reduction information that's available on some of the websites, and the feedback card, and goodbye and thank you. So if you want to find out more about these portals, an amazing amount of information on it. If you're working with young people, there's a Assist Youth, which is for 10 to 14-year-olds. There's one for 15 to 17-year-olds. There's one on methamphetamine. There's training available on it. Matthew Stevens, who works with Robert Arlai, runs weekly trainings, probably not coming up now. There's also some great resources available and videos on how it's administered that might give you a bit more of an indication around that. So just quickly to summarize, last slide of the presentation. Thank you for hanging in there. And for those of you who have attended all 4 of them, alcohol and drug use costs us a lot of money in Australia, as well as a lot of deaths associated with us. And this was a research coming out 10 years ago, was estimated to cost the community about $56 billion. A lot of this is health and hospital system. It's also accidents. Many people, have got hangovers, don't go to work the next day. Again, because most drugs are illegal, many people participate in crime. And then there's also the costs associated with the prison system. Some really exciting news coming out of the ACT this week is basically the ACT government's looking at decriminalising all drugs, which is a great outcome. And I'm a very strong believer in that we need to do decriminalisation, because much of the harm that happens with our clients is getting caught up in the criminal justice system. So it's the legal drugs that are costing us the most amount, as we talked about before. 22% of the cancer burden is associated with tobacco. So, the less people smoke, obviously, and we will start to see this reducing, except for if the vaping industry gets in there, as we talked about in session 2. Alcohol costs us a lot of money too, even though we collect $7 billion from taxation with it. And again, I wish the alcohol industry would stop its advocacy, and similar to the coal industry with parliamentarians. It's and they're having a lot of impact in our policy there. And illegal drugs cost about half what alcohol does, but still real area of concern. And this, obviously, as I said before, with all of the early death that happens from people who use illicit drugs, and the years of life lost. So on average, 33 years of life, as we said before, are lost with people who overdose early. Any questions there? Just taking you up to 11:30.
We don't have anything in the chat, but certainly encourage anyone who's online with us to ask their question.
Does anyone
I don't have a question, but I was just
Go, Mandy.
Oh no, mine was a comment, and it was actually just like I was just going to say I can't believe how much information you have. And that you've been able to share with us, Annie, is so amazing. It's so amazing. You're just a wealth of knowledge and experience. So I feel like we've been really lucky to have your time over these last few weeks.
Thank you very much, Mandy. And look, if there's any other sort of questions, Gail will send out the PowerPoint in the next couple of days to you. Please click on the links. If you've got any kind of questions and comments further, or you're stuck with anything, I'm happy for you to email me, and I'll try and help you, or go through Gail or Mandy. I think I provided some information around kind of the alcohol industry getting into the non-alcoholic drinks market, but really happy, and I've got some great websites that are also kind of included here, again, where I encourage you to go for further information, and particularly if you're working with clients that are using drugs. The New South Wales Users and AIDS Association website is fantastic, and these guys also keep you up to date with the drug alerts. You can also follow them on social media as well if you just want to keep up to date with kind of what's happening, and they will administer these drug alerts as soon as they hear that there's a drug available. And until we can get drug checking happening in New South Wales, we're going to just be looking at the ACT and what happens there. So but again, most progressive jurisdiction that we've got. The other thing I just wanted to do, one of the things I produced for the assist, and again, if you don't want to kind of download or print a copy of all of the information on the website, on the assist website under you can see it there on the right hand side of your side. So assist tools. I've produced a whole lot of fact sheets on all of the drugs that we've discussed. And it's basically, these are shown there, what the street names are, what are they, what does it look like, how's it usually taken, short-term, long-term effects and issues for consideration, and then some harm reduction advice. So these are just 2 pages that, are really good kind of tools to have at your fingertips, which I encourage you to get a hold of. And the Assist website's really good if you're interested in finding out further information. So for those people that are still online, if you wouldn't mind filling out the webinar evaluation, this is all anonymous. I won't be sharing the results of it. Be really happy to hear your feedback on it. And thank you for those of you who attended today and attended the last 3 webinars before that. It's been really great working with you, and well done for surviving what has been a difficult year. Let's hope 2022 is less challenging than the last year was. I know we were very relieved that we'd all survived 2020, and 2021 turned out to be a little bit more challenging in a lot of ways with COVID, and got a long way to go with that. So please fill out the evaluation, and thanks very much for your attention, and have a great summer break, and forward to meeting you at some stage face to face somewhere, somehow.
Thank you
Thanks,
so much,
Annie.
Annie. And again, there's many thanks that we're seeing within the chat section as well. I'm so grateful that you've found value in these series. And just before we jumped on and let everybody in this morning, I was chatting with Annie around looking at how we will stay connected with Annie over the length of the program. I didn't tell her the length of the program, but you know, she'll work with us for a small fee. But anywho, we will be working on what else can we add value to in the work that you do in CDAT land, but also how does that contribute back into the work that you do within the positions that you hold with the organisations that you work for. So I'm glad that you have found value in it. And again, Annie, we are ever so grateful and very fortunate to have access to your knowledge, that breadth of experience that you have in this industry. It's tenfold, and it's certainly of value to everybody. As Annie's mentioned, we do have the PowerPoint series that'll be coming out. More than likely that you'll see that come from Mandy, not myself, my lovely helper in the background there. So thank you, Mandy. Just really want to acknowledge the staff as well, the CDAT staff who have helped me behind the scenes in ensuring that we do deliver valuable content to you that's usable within your everyday work. So again, thank you so much. Have a wonderful break. I do echo the sentiments of Annie as well, that we've come through not just 1 year, but 2 years of very unusual time. So here's to 2022 with a fabulous festive season. Rest up, and we look forward to seeing you all again soon. Thanks so much, everybody.
Thanks a lot.
Thank you.
Take care.
Thank you.
Thank you. Thanks, Annie.
No worries. Have a
Thanks,
Thank you.
Thanks, guys.
Thanks, Annie. Thanks, Gail.
no worries.